Thank you for coming. Hope you all got enough food. This is Pediatric Surgical Oncology in the Dominican Republic, so you're in the right place. I'm Alex, and I'm a first year, and I'm Lincoln, I'm also a first year. And we're just going to actually have our guests introduce themselves, because you guys can probably say whether 2 seconds something.
My name is Chris Weldon. I'm a pediatric surgeon at Children's. Thanks for inviting me.
I'm Paula Friedrich, and I'm a pediatric oncologist at Children's and Dana-Farber.
And I'm Carlos Rodriguez, I'm also a pediatric oncologist at Children's and Dana-Farber.
Sorry, could you speak up? It's hard to hear with the fan.
Yes. So Chris Weldon, pediatric surgery, and Paula and I are from pediatric oncology. And we have with us also Dr. Frazier, who's sitting there, who's also another pediatric oncologist, and we all do a little bit of global health as well.
So we brought them to come and discuss a project that all three of them work very closely on improving pediatric surgical oncology, specifically in the Dominican Republic. So basically, our hope for this is that everybody's going to be very interactive. So Alex and I are going to present a few slides. We have some questions that we're going to present to all of you. And then we're going to ask our guests to kind of fill in other ideas as well as give some more background.
Can everyone hear, like, person back there in the corner? All right. If you guys want to move to the front or maybe all to the left side so we can make this talk to one side.
I'm going to start with just a few basics about Dominican Republic. A lot of these facts are in the handouts that hopefully you guys grabbed when you came in. So technically, according to the World Bank classifications, the Dominican Republic is an upper middle income country, yet about 35% of the population lives in poverty. Gross national income per capita is about $9,000. So my first question is, how can it be that it's an upper middle income country, yet over a third lives below the poverty line? You guys have any thoughts about that? Or
Income disparities.
Bingo! Income disparity. So the rich are wealthy and a lot of people are not. So this has implications on health outcomes and healthcare in the whole country. The national expenditure on health is about 6.2% of the GDP. The life expectancy at birth is 73. So does anyone know what it is in the U.S.? Male, female. It's 76 for men and 81 for women in the U.S. So it's not that big of a spread, right? They have near universal health coverage. According to the Dominican National Health Plan, the main challenge in the Dominican Republic is not the coverage, but the quality of services. So as our top, we are trying to improve the quality of care. Communicable diseases are still one of the #1 causes of child mortality and hospitalizations. So that's something else to think about when you have one hospital for children. You have children who are immunocompromised, who even though they're in a different ward, just different things to think about. So, Dr. Arturo Grullon, Regional Children's Hospital, I practice saying that frequently, is the hospital that our lovely doctors are working with. It's a public hospital. They have radiology, pathology, pharmacy, they have infection control, the Pediatric Hematology Oncology Unit, which is UHOP in Spanish acronym. Opened 2005, was renovated in 2010. They have a small pharmacy within the hospital. They have nuns who live in the hospital and run the pharmacy. In general, take care of the children and help out with things. They have air conditioning, phone and internet. So it's a decent establishment. The facilities are pretty good.
Yes, I would say sort of the pediatric hospital is sort of the typical setting of a pediatric hospital in lower middle income countries. It's a regional facility, meaning that children in the northwestern part of the country that have anything that can be managed at the setting will be referred there. So it ends up being a very high, the general hospital is a very high volume hospital. And the other sort of model that happens is sort of specific areas of the hospital get an input from local NGOs and do better than the actual hospital. So the main hospital doesn't have air conditioning in most of the rooms, and it's shared rooms. But the pediatric oncology unit there's a local foundation that raised a lot of money to build it, and it looks 10 times better than the rest of the hospital. So it's only the pediatric oncology unit that has good air conditioning, computer, good lighting, is nice and clean and beautiful, full of colors, and looking like a pediatric place. Most of the rest of the hospital looks much less developed.
Yes, there's a picture in the corner of the hospital, and so like really that could come out of any of our hospitals here, bright colored murals. So the patient demographics of the hospital, they come from all income levels, but it's primarily low-income households. The travel time to the hospital can be up to 6 hours. Children come from Santiago, which is, we're in the Dominican Republic, which is in the Caribbean. Santiago is where the hospital is, this purple circle. It serves the Cibao region, which is the north region of the country. Patients also come from Haiti, which would be over here.
Actually, close to 20% of the patients in the hospital like to be from Haiti that cross the border
For medical care.
for medical care.
So this is an additional thing to think about in terms of if the child has to have a treatment every day, every week. Are they going to stay in Santiago? If they have to come back every week, are they going to travel back and forth a few hours? Just different things to think about. The Pediatric Oncology Center has grown. So 2005, when it opened, they saw about 5 children a year. This is from college report. And in 2009, they had an average of 42 admissions, 49 outpatient consults per month. Huge expansion in the patient population they've seen. So this might be kind of a trick question, but pediatric oncology, pediatric cancer is a genetic disease. How is it that in 4 years you're seeing this enormous growth of patients? More children have the disease. Is that
Detection.
right? Yeah. So with increased awareness about pediatric cancers, earlier detection, more kids are diagnosed.
But remember, that's probably still below expectation, right? So in that area, you would expect probably twice that number.
Well, three times that number.
So again, there's a lot that needs to be done to make sure that these patients come. If they don't come to this unit, it doesn't mean that go somewhere else. It's just that they don't go anywhere, right? So these are kids with cancer that are being, undertreated or underdiagnosed and they die.
And because our initial reaction was to say, well, they're probably seen in Santo Domingo, which is the capital of the Dominican Republic, and the other place where there's a pediatric oncology unit. But looking at the number of patients that Santo Domingo sees, you still don't make it to 100%. So I think even though the Dominican Republic is a small country, in theory, with a regionalized healthcare system where there should be access to primary care, you're not talking about a very difficult landscape. It's actually not big mountains or very far away roads or things like that. Access to care should be somewhat accessible. What is happening that the kids are not being referred? Because I don't think that they're not getting to the primary care doctors. It's that maybe they're not getting referred past that. So this is much lower than what they should be seeing.
So Dana-Farber works with the Dr. Arturo Children's Hospital, and they have a twinning program. So I just want to start, does anyone want to just briefly shout out what a twinning program is? Does anyone know what a twinning program is?
hospitals here work with partner hospitals in other countries to help provide some of the services that they don't have there and some of the expertise, and both through travel and through like phone and video.
So that the hospitals there don't have to kind of reinvent the wheel in terms of let's come up with how we cure cancer. They ask doctors in more developed countries to help.
Yeah, so maybe Paula, you can explain. Do you want us to explain how we set up the 3D, or you want?
Sure. Briefly. Yeah.
Okay, Paula.
So the twinning model is exactly as you were explaining. It's sort of it's supposed to be a partnership, and we really try to make it a real partnership where we feel like we are learning from them and they are learning from us. Because one thing we quickly have realized is that many of the things we do are not applicable in other settings. So it's not just a matter of them saying to us, oh, I have a child with this disease, what do I do? And me sending our best protocol there and saying, here you go, and now, just apply that. It's not a recipe, kitchen recipe. So we actually have to learn a lot about their context as well and what can be applied and the history of how we have treated patients to get a sense of what is applicable depending on their development. And so the idea is to have a big component of collaboration and partnership both ways. And in the Dominican Republic, and this is a model that has been used in many other locations. So it's not a model that we invented. It's a model that has been used by many other institutions as well. So in the Dominican Republic, we started now 2 years ago with what we call sort of a needs assessment, just even going there, figuring out the major needs, where things stand, and often also allowing them to acknowledge all that they've done so far on their own, because I think they sometimes see us as here we come and we're going to solve all of the problems, and that's not necessarily, we try, but it doesn't necessarily work that way. So it was a lot about allowing them to, or helping them understand the things that were happening and some of the things that they need to move on to the next step.
No, the twinning is at all levels. It's nursing, oncology,
Presentations about surgery.
Right, so it's a long journey. It's just we're going to walk with you, right? It will take 3 years, 5 years, 25 years, and there are 20 programs that have been going on for 20, 25 years, and you grow there. And then twinning, basically what you're saying, we don't talk about you and us, right? It's us, right? So we are the
We're going to present one patient case later in the presentation, but just to give everybody who's first year or less, not necessarily has been in hospitals, a bit of background. The patient is most likely has a Wilms tumor, which is a kidney tumor. Sometimes it's called nephroblastoma. At least in the U.S., it's the fifth most common pediatric malignancy. It usually arises between ages 2 and 3. Almost all are in children under 5, and it's very curable with good surgery, good radiation, and good chemotherapy. This is the basic kind of outline of what we do in the U.S. So when a patient presents with an abdominal mass, you're going to get some kind of imaging. Ideally, the COG protocols call for abdominal ultrasounds, chest CTs to check for metastases, abdominal CTs. And Chris, would you like to comment on why the contrast is so important?
Yeah. So before you know what to do, you have to diagnose as best as you can the enemy that you're in. And when it comes to pediatric oncology, if you take a step back, 100 years ago, the tumor was 100% mortal. There were no survivors. They quote a risk at the turn of the 20th century of roughly 5% survived, although you'd be hard-pressed to actually find it. I don't think anyone wants to publish a survival rate of 0, so they threw out 5%. And one person got together and said, well, I'm going to do something I can operate. And that was a pediatric surgeon in children's named William Ladd. And he took the survival rate single-handedly from 5% to 30% the first 2 decades between 1915 and 1935. And then also in Children's Hospital, they essentially primarily used adjuvant therapy, both chemotherapy and radiotherapy. And by 1965 to 70, they took a survival rate from 5% to up to almost 70%. And everyone working together on one tumor was really the dawn of the multidisciplinary care of a single disease in all of medicine that started out with this cancer. And the COG protocols were actually built, and that stands for Children's Oncology Group, on a focal group called the National Women's Tumor Study Group, which was a bunch of people who were all in and around interested in Wilms tumors from radiology, surgery, oncology, radiation oncology, you name it, but especially epidemiology statistics, to develop studies to apply to a nationwide population to determine what kids need more treatment and what kids need less treatment. Because what we have to remember is our success rate isn't measured really in 5 years, it's measured in 5 decades or longer. Because if you have a child who's 2 who has this, you don't want to say that they're okay at age 7. You want to say that they're okay at age 70, and that their children and grandchildren and subsequent generations all make it. So we have a much different outlook in pediatric oncology than our adult counterparts, because though we love grandma, if grandma makes it 5 years past her diagnosis of colon cancer, that's great. It's a lot harder to lose the child. And that being said, the group protocols that we develop really want to know first and foremost where the tumor is and where it isn't. And contrast is utilized almost throughout all of oncology to figure out whether the tumor is attached to, invading, or has elements of tumor within the vascular system. And that also can go to the urinary tract depending on when the actual contrast is shown. So it really tells you just not a lot about where the organ is started from, but also the vascular supply to that organ and whether the tumor is growing out the arteries.
So after you've done all that imaging of a patient in the U.S., hopefully it would be considered resectable, and Chris would take it out.
Yeah, and I mean, this isn't just U.S.-based protocols. I mean, even our European counterparts or counterparts in Japan or other parts of the world, where, shall we say, there's definable care standards. We may not all agree on the precise drugs utilized or the timing of surgery, but the workup of the child really is pretty uniform. You need imaging studies, you need quality studies, and you need studies to define where the tumor is and where it isn't. And contrast is utilized throughout the world. And then after we know that the tumor is resectable, and we look at criteria to primarily say that the child will survive the operation, or that the child will not have an increased risk of having a severe post-operative complication from the operation, we then would recommend an upfront operation to remove the kidney, the associated tumor, and the lymph nodes in and around the drainage pattern of the kidney.
So, Chris, what would you define as resectability?
Resectability.
I can take this into the operating room tomorrow, and this is what I need.
So first and foremost, you have to make sure that the child isn't critically ill for some other reason. These tumors are large, they can cause respiratory embarrassment, they can cause other perturbations of the child's cardiac profile. You have to make sure that the child can withstand the rigors of anesthesia and the surgery in and of itself. Sometimes these blood loss can be significant, so you want to know that they can make it. And so you work with your anesthesia colleagues and your ICU colleagues to really assess that this child is a stable risk for the procedure. Once you determine that they'll have no increased risk from an intraoperative or perioperative mortality or severe complication, you then look at surgery-defined risk factors. What I mean by that is you want to make sure that the invasion of the vascular stream, which is where contrast is critical, is not such that that would compromise the child's ability to make it through surgery without an untoward event. And what you're really looking at in essence is that the tumor isn't growing out through the venous system, through the renal vein, into the IVC, and all the way into the right atrium. As long as the tumor is essentially below that level where the hepatic veins meets the IVC, you should be able to resect it with a fair bit of certainty that you're not going to cause an increased perioperative risk.
Regardless of the size?
Almost regardless of the size. At the end of the day, one of the other important factors that we want to know is that the tumor isn't going to perforate or the caps will be violated and spilled, because that would upstage the child. These tumors are often quite large. The kidneys, as you know, are their back part of the body. It usually takes a while for them to grow, and they're usually found either incidentally or accidentally for some other reason. And usually when they're found, they're pretty big. The standard tumor, I would imagine, would be at least probably 10 to 12 centimeters in size, if not up to 20 to 25. So regardless of the size of the tumor, if there's no evidence of vascular involvement or a minimal amount of vascular involvement, and the child is a standard good anesthetic risk, then we would recommend to proceed with surgery.
And then after surgery, the oncologists come back and they do, so if it's a very, very low risk tumor, actually Chris cures them and he does surgery and we watch them and the child is done. If they're not,
That's age dependent.
it's age dependent, tumor size dependent, but so the vast majority of cases come to Paula and Carlos and they get chemotherapy or chemotherapy and radiation depending on the stage of the tumor, which includes things like metastases. As Chris mentioned, if the tumor ruptures, so if there's any kind of blood in the abdomen from the surgery, that spilling of possible tumor cells upstages you. It's just a basic idea of how this gets treated.
Think of spilling as a water balloon. If the water balloon is popped, there's no way to control the outflow of water, right? You can't grab it quickly. There's not a spout or a spigot or some other means to tie up or hold. Once the water balloon is popped, fluid leaks out, soilage is unfortunately happens.
So now we're going to present the first bit of our case. So GM is a 4-year-old girl, and she came on January 14th to EPOP. She had severe right-sided abdominal and flank pain and abdominal distension for about 10 hours before she came to the hospital. The doctors on exam found her to be very pale. She had many swollen lymph nodes, and her abdomen was really tender, even to slight palpation. So for the audience, what do you guys want next? What other information do you want to know? Alex gave you some background on what's available at the EPOP Center.
I just want her vital signs stable.
She's stable. She's stable.
Imaging?
What do you want first?
Ultrasound?
Ultrasound. So yeah, you want to know ultrasound first, because then you're not exposing to radiation in case this maybe is something, you know, maybe it's just really, I don't know what else it could be, really bloated from like constipation or something.
It's always easy to get an ultrasound.
Yes.
Really in contrast with the other thing, they keep moving around.
And there are non-oncological processes that you would say would be far more likely. It doesn't have to be a liver. It doesn't have to be a renal tumor. It doesn't have to be a childhood kidney cancer, childhood liver cancer, childhood germ cell tumor. It could be other things, esoteric cysts, duplication cysts, other weird embryological phenomena that can present in children in a young age. They're okay at birth, but unfortunately as they go through the early part of their life, these processes can grow by collection of fluid, mucus, or whatever else the process is. So, you know, yes, we always want to think the worst, but it doesn't necessarily always have to be a malignant tumor. It could be a benign tumor from some other thing.
So, in the Dominican Republic, they do have ultrasound available. They have CTs available at the hospital. If the doctor, well, if they needed MRI, nuclear imaging, they'd have to go to a private clinic. They would probably have to pay for this out of pocket, or the public insurance might pay for it. They have no PET scans. They also have pathology, but it's basic. So morphology is mostly determined by H&E. So think back to first year histology, and that's what you're using to diagnose the pathology of the tumor. And Carlos, can you tell us why that's so important to know? Pathology of the tumor? Yeah.
Yeah, it's very important. Because you need to know what you're treating. But not only that, not all renal tumors are Wilms tumors, right? And not all Wilms tumors are created equal, right? So you need to first make sure that you have the correct tumor, which is a Wilms tumor, but it could be a rhabdoid tumor, could be something else. And then within Wilms tumors, you still need to see if the tumor is what we call favorable histology or unfavorable histology. And that's because of the presence of aneuploidia. And you adjust the treatment, and you can anticipate prognosis based on what you see. So you need to be very careful. You need to review the pathology very well, identify the tumor, then make sure that you can stage the patient properly, that the tumor is not invading the capsule, that the lymph nodes kids are not involved, etc. So pathology is key.
And remember, I mean, if you think about it, morphology was good enough for 100 years, if you really want to look at it. And it's only now that we get better and better, and science is really getting better and better at trying to parse out the good actors versus the bad actors that molecular studies count. So, and what you're really trying to do when you're trying to use molecular studies is figure out, again, those kids who need less treatment versus those kids who need more treatment. Because you don't want those who need less treatment to be subjected to more treatment to get all the risks of it with no benefit. But yet you don't want to undertreat the kids who really need more treatment. So, you know, if you just take a step back and say, well, we went from a survival rate in 100 years of 5% to 95% for low stage, good histopathology most tumors. And we did a lot of that without any molecular studies. So if you take a step back, in a country whereby you could institute that using, shall we say, protocols from 20 or 30 years ago, from a public health standpoint, from a care delivery standpoint, you can make a huge impact without trying to get really fancy really quickly. And so there's a lot that can be done. And maybe one caveat, have you guys talked about or heard about the effects of CT scans and the risk of secondary malignancies, especially in young patients? So that's really coming to the fore in all of pediatrics and not just oncology. Obviously, we as oncologists get hit with this all the time because in the lay press, it's cancer, cancer, cancer from a CT scan. But there's many advantages to a CT scan. One, you can do it very quickly. The child doesn't need to be sedated or have anesthesia almost regardless of age. And two, you can usually get great contrast administration, whereas MR is a lot trickier. So even though MRs are going to be advocated in many protocols and studies here, it may not be applicable in other countries, and the CT scans can still certainly do the job.
Not yet. It's a great question. But not yet.
We need to think about. I paid her.
There's something to think about, though.
I had a question. Before you guys started twinning with the hospitals, they have these imaging machines and like in places or hospital systems that don't have them, are they able to still achieve like pretty good, successful cure rates?
So in terms of their, so as I was saying, very often the hospital and the oncology unit can be very different. So at the hospital, they have ultrasounds and now very recently a CT scanner. But most of the other types of imaging and even sometimes the CT scans, they actually what they end up doing is that the local foundation, which raises money for the kids with cancer, pays for the kids to go get their imaging at private institutions. And as you were listening at the beginning, the Dominican Republic is a place where there's a lot of disparities, and the public healthcare sector is probably as healthcare was here 50 years ago, or probably even more, and the private sector can be exactly as if you were here. So you actually, if you are able to access what's available in the private sector, you can actually get exactly the same quality as here.
If you would like say you couldn't access the private sector with surgeons in the public hospitals operate without, is that
So that's a little bit what I think we'll talk later on. I mean, it's one of the biggest challenges we realized very recently. So I think most, as I was talking before about twinning program, one thing that I forgot to mention is that most of the experience that we have from twinning programs come from leukemia and lymphomas. That's sort of most of the outcome. In pediatric oncology, we have a little bit of a bias to focus on leukemias and lymphomas because they're the most common pediatric cancers. And they're also the most treatable. The pediatric oncologist is really sort of the leader of the team, and you and your chemotherapy can go and cure children. So it's not exactly a one-man show, but it's very close to that. Sort of, you have a lot of power as a pediatric oncologist. With any solid tumor, that's not the case, and I think so. Our focus is more in solid tumors, and as we've learned about how to do twinning program beyond leukemia, we've come to realize how important it is to keep having to take into account all these other services and the quality of all these other services. And for example, in this case, so we had already been working with the Dominican Republic for over a year when Chris came with us for the first time. And we had been struggling for a while, asking like, why are we having so many relapses? Why are the kids not going into surgery? Why are sort of some of these things happening? And as we will see with this case as well, we soon realized that that's a lot of the problem, that all the other, so maybe the surgeon is not willing to go to the OR, maybe the anesthesia is not quite where it should be, and some of the other things that are completely out of what we usually consider our team are actually very, very important to get even basic therapy done.
Let me follow up on this question that I would ask Chris Weldon. So, in a patient like this, if you only have an ultrasound, you have a tumor, you think it's solid, you think it's a loose tumor, and you cannot get a CT scan in 1 month because beyond the scanner in your region is down, would you take this patient to the operating room? If that's the only tool you have, either chest X-ray, you have metastasis, you get this. You can see material, so you think it's a
So remember, CT scans really weren't, shall we say, utilized extensively until really the 90s. They were obviously created in the 70s, became popular in the 80s, but really didn't become commonplace. And ultrasound too wasn't really a phenomenon that was utilized to the degree that it is now until really the 80s and 90s as well. So we're really talking about techniques in the last 2 decades. So if this child presented, abdominal mass, and you really don't know where it's from, you can try and do x-rays, plain x-rays to get an idea. Sometimes you get IV contrast and then shoot an x-ray, you can get an idea if it's coming from the kidney or not. It's called intravenous pyelogram, although they're not perfect. But at the end of the day, you don't know. So you could still explore and figure out where it's from and try and determine whether the child would be an operative risk on the table. It was done for decades, and it was a great deal of success with careful patient selection. If you only have an ultrasound is very good at telling you whether there's vascular involvement. So if you have a child with or without pulmonary metastases, if you think you can get through the operation safely from the anesthetic standpoint, if you have a good ultrasonographer or you do the ultrasound yourself, you determine that there doesn't appear to be vascular invasion into the renal vein, and as we described out of the IMC, I would proceed realistically to take out the patient and see what was there.
The good thing is most of these children, they're small, so ultrasounds in adults are not used as often because you have to go through layers and deep fat. With most kids, that's not the case, so you can actually see a lot with an ultrasound.
What's the life expectancy for someone with a child where you really need the most?
Leave it in.
Yeah.
0. Even with chemotherapy, the idea of antibiotic resistance for bacteria is the same analogy for, shall we say, oncological resistance with chemotherapy. You will have a Darwinian effect where you select out cells that are going to be resistant to that therapy some way, somehow. And the idea of chemotherapy of using different drugs from different classes to combat the cells from multiple standpoints, regardless of whether you use that or not, it still holds that probably eventually you're going to get a resistant clone that will then subsequently grow and metastasize and cause further.
So if it's not resectable, do you use chemotherapy first to make it smaller and then until it's resectable?
Or if the child is such a bad operative risk, you have no choice. Or if you live in France.
So, but remember in oncology, maybe that's the last.
Yeah, I would say we should probably move on.
Yeah, no, but in oncology we have, a golden rule which is local control. So chemotherapy can only go that far. Like you need to do local control, which is surgery, radiation. So chemotherapy beyond cure the kidneys. Oncology, you need surgery.
So these were kind of the basic diagnostic imaging. So there's a large renal mass. Remember, this is a 4-year-old. I think 4-year-olds are like 3 feet tall. They're short, they're tiny. So a 10 by 9 centimeter mass is huge. So 10 centimeters for all of you kind of non-Europeans out there. She's slightly anemic, and she has a slightly high LDH, but otherwise her her lab values were considered normal. They were actually able to get a CT scan done the same day that she came to the hospital, which is great for this case. That's actually not all that common in a lot of developing countries. Often you have to wait several days before a CT scan.
So visually, just to give you an idea, your kidney should be about the size of a lemon in some of this age, and she had a cantaloupe. Think of it that way. That's the difference.
So we'll just briefly go through this since we already told you what she has. So this is the chest, and what is that white thing? Heart. And as we go down, we see her liver. Right? And then,
Something that should really not.
and then as we go down, you should see kidney. I'll be honest.
There's a pointer, but it sometimes works. It's
Well, that
doesn't.
So the first rule of medicine is always make sure that you have
Right.
have a point. And then always make sure you have the right patient, the right date, and the right scan. Many times you walk down, you have the wrong name, the wrong child, the wrong business. Make sure you're looking at the right thing first and foremost. And then what you can see is, so anything with air in it is black. So your lungs are black. This is the outside of her body, which is also black. Anything that has a density of bone or calcium is white. Contrast material is white. It does not necessarily calcium-based contrast material, but it does the same thing. So anything that is very, very dense is white. So when you give contrast, the vessels will be white. Heart is white because it has blood in it, and the blood is filled with contrast. So the heart is predominantly white, lungs are predominantly black, filled with air. These are your bones. Okay, so as you go down, this is starting at the one tumor right here. This is her liver, right side of the abdomen, left side of the abdomen, front, back. You can always use your vertebral bodies and obviously give you an idea. As you start to go through medicine, you get better and better just looking at these and just knowing, because liver, spleen, the liver is being pushed over by this very large renal mass that you don't even see normal kidney. Okay?
So here's more of the upper.
So, liver, just keep following the lower left hand. And you start to see some normal kidney right here, and then the contralateral kidney on the left side. You see how the contrast is densely white in the center of it? That's not blood, that's urine. Because contrast, the agent that they use, the reason why they don't use calcium, is that it's excreted into the urine. So it not only lights up the vascular tree because it's administered through an IV, but once it's processed through the kidney, it's excreted, and it also retains the density of the contrast material to make the collecting system white as well.
Say something.
Oh, of course. Oh, we have more pictures. And there's the good one that has the really obvious X marks the spot with the tumor.
I should mention these are very thin cuts, right? So here we do very thin cuts, so we have much more kind of a cleaner way at the tumor. Here you saw that we come from the lungs all the way down to the liver, so probably it's big cuts. And so for proper imaging of the tumors, you want better cuts. So
And that's technology. So this is a single slice CT scanner that will get you a centimeter. The thinnest cut it will do is 1 centimeter slice, and that's a single detector CT scanner, which essentially was the first model that came out. They now have CT scanners that are 512 slices at a time, which you can then recontrast to essentially give you a slice down to 0.01 centimeters up. And you can use those to do volumetric 3D reconstructions on multiple planes. So you can get very, very thin to give you precise anatomic definition. That is air in the gut. So air in the lungs, air in the gut. That's all distended valves. Because you know these large tumors will compress the gut, and they're going to give you ileus or even a mechanical valve obstruction.
So Chris, having seen this, you found out that the child is stable, and you are ready. You've decided you're going to do surgery. Can can you talk a little bit about what would be your surgical approach? What would be your concerns?
So one of the first things you have to do is remember that sometimes these are bilateral. Meaning you can have two present at the same time, or you can have other embryonal, what we call nephrogenic arrests that may or may not. And what you can't do is make a child anephric. You can't remove all the kidney tissue at once and commit them to a lifetime of dialysis starting at age 2. Believe it or not, they tried that in the late 60s. There's a group out of San Francisco that thought that they would remove all the tumors up front, then give chemotherapy to the child on dialysis, thinking they'd give more dosing because they had less renal toxicity, and then they would undergo renal transplant, all within a very short period of time. Sometimes, in a few children, they actually did the resection and then put the transplant in right away. Now that's obviously before they really understood what immunosuppression was and how to guide it, but we know that that's probably not the best option. First and foremost, and one of the most important things you do, whether you have imaging or not, is to make sure that you don't have a lesion in the other kidney. Because if you have a lesion in the other kidney, you have to remember, we're talking about a 7-decade success rate. We're not talking 5 years, right? 7 decades. So you need those kidneys, or whatever left of them, to get them through life. If you remove a single kidney in a child, they can still live a normal, healthy life, and the risk of renal failure over the general population with a single kidney removed in childhood, whether it's for trauma, tumor, or some other reason, is minimally elevated over the population, 0.25%. There is a higher risk of hypertension, and there's a higher risk of other things with a single kidney. But we've got pretty good long-term survival data, at least going out now 3 to 4, even 5 decades to tell us it's not worse. So we know that you can make it through life with one kidney. Why? Because we have a lot of people who undergo renal transplants with a single kidney. Anyone think of a professional athlete who played sports with a transplanted kidney? He was a basketball player, Alonzo Mourning. So he lost his kidney secondary to a chronic medical disease as well as NSAIDs. And he had a kidney transplant and then went back to playing for the Miami Heat. So you can do a lot of things with a single kidney to grow and develop a kidney. But you want to make sure that you don't have something in the other kidney. If you do have a lesion in the other kidney, then your best option really is to biopsy the lesions, in my opinion, figure out what the pathology is, and then start chemotherapy after surgery to, in essence, try and shrink the tumors, to then go back another day and fight to partially remove tumors from the kidneys and leave as much renal parenchyma behind as you can.
In this case, so you think that it's resectable from what you have seen?
As best as I can tell, the answer would be yes, but understand there's a little bit of a limitation with the contrast material. The inferior vena cava isn't lit up as well as we would like, but I would certainly explore the child to return.
10 days after diagnosis, which again is actually not a bad length of time for being in a developing country. She went into surgery. As you saw, her liver was pushed all over where it should be. The tumor was adhering to a bunch of the abdominal organs, and so Chris, you could just mention a little bit about how you actually go about removing adhesions, because you also talked earlier about the importance of keeping that capsule whole.
So at the end of the day, I don't think any of this is surprising. Okay? This is a retroperitoneal structure that's going to push things out of the way. If it frankly invades an organ other than the colon, then you would have to think twice about trying to do the resection. So you don't want vascular invasion, especially growing out the IVC to the right atrium. But if it's growing into anything other than the mesentery of the right or left colon or the colon itself, you would think twice about trying to resect it. Why? Because that would portend to a much greater operation that would have far more risks and post-operative complications that in essence would probably delay the use of chemotherapy, which we know at the end of the day is as critical, if not more so, than surgery for cure. We know that surgery alone doesn't do it, so you need the chemotherapy. So don't do an operation that delays the issue. If you were to have to resect the pancreas, spleen, or some other organ, then you can think twice about trying to do it right.
But from our understanding, this was basically not, this was touching things but not invading.
You never know unless you're there.
But we're not sure.
But it would be part and parcel standard for a tumor of this size to, shall we say, push a lot of things out of the way and things that kind of be stuck. But unless you really try to dissect it to remove it, you wouldn't know. in our hands, we probably would persevere on and see what we can do to try and, shall we say, move things out of the way to really determine whether there's a patient.
And the last thing is there are about 150 cc's of blood present in the abdominal cavity. So we don't know if this happened during surgery or if the tumor had already ruptured prior to surgery. But this will automatically upstage the patient, because whereas before all the tumor cells were definitely in her kidney, in the capsule, safe, they can't get out into the rest of the abdomen. The blood implies that there was probably some kind of tumor leakage. There could have been, so tumor cells could have been released, which means if she needs radiation, which she does, instead of just radiating the right flank and the right kidney, like where her right kidney had been, they now need to radiate her whole abdomen.
And at the end of the day, she presented as such that she perforated prior to the operation. Children with Wilms tumors generally look fine. The standard practice is, oh, the kid is great, looking healthy, looking happy, and somebody picked up the child who hadn't picked up the child recently and said, what's this thing? And they feel the abdominal mass. But these kids come in healthy. They look healthy, they're toddling across the room, you're like, they don't look sick. And so for her to come in like she did, lethargic, pale, sick, anemic, you would assume that she probably perforated in advance.
What the surgeon actually decided to do, decided that he couldn't resect it for whatever reason. So he took a biopsy of the tumor, which goes back to Mary's question. Because we think this kidney had likely ruptured, the surgeon didn't innately change the outcome of this patient, but had there been no blood previously to surgery, this would have automatically upstaged the patient. Because of the same thing, you are exposing the abdomen to other possible tumor cells. He removed several lymph nodes, which, as Chris said, is standard practice. Washed the abdomen and closed.
So Chris, how many times trying to resect the Wilms tumor you have had to close without resecting?
0.
Is that because of but is that because of how you get to choose your patients?
A great degree of it is that, to be honest with you. And furthermore, we can know in advance just not what the radiological risk factors are, but the entire perioperative principle. Even if the tumor is perforated in advance, you've got to think about it. This is a little child who's got a cantaloupe sitting in a place it shouldn't, compressing bowel and other things. They may get a great deal of relief just by, in essence, removing the tumor and, shall we say, debulking the abdominal cavity, even if it already is perfect. So there may be a lot of, shall we say, physiological benefit to removing something of that size.
Just about the chemotherapy, is a standard chemo protocol for those who need an affect fertility?
So chemotherapy can affect fertility always. The chemotherapy that we use for a Wilms tumor, that we'll talk later, doesn't really affect fertility that much. So yeah, there are acute and long-term side effects.
And then when they had a rupture intraoperatively, is there any role for chemotherapy?
Good question. So I think that with what we know right now is that we can cure these patients still pretty well with chemo and the dose of radiation therapy that is not excessive. So we don't use intraperitoneal chemotherapy, but the peritoneal chemotherapy is used for other reasons in adults and also in pediatrics. It's a little more toxic. Can be done there.
To answer the biopsy question, because you mentioned if the child had been in France, it would be different. Do you want to sort of go back to that comment?
We're going to talk a little bit.
You're going to talk about that? Okay.
We're going to try to move things forward as we can.
Okay. And then I think there was a question back there.
I was just wondering what the risk of recurrence of cancer is, and if it varies based on whether you remove the entire kidney, or if you're active for other cancers.
So for childhood kidney cancer, pretty much at all times, other than lymphoma, the recommendation is a complete nephrectomy, meaning removing the entire kidney. There is no role in our current studies for a partial nephrectomy, except in the case of having tumors on both sides. Because all the data is based on removing the entire kidney. This is not like an adult renal cell carcinoma, whereby you can get away with doing partial nephrectomy with the tumor. The risk of recurrence, therefore, is hard to detect because most kids don't have partial nephrectomy.
So the surgeon opened the graft, took a very small biopsy, sent it to pathology. 8 days later, it came back, and the lymph nodes showed there were just reactive processes, so basically there was no tumor infiltration to the lymph nodes, and the biopsy showed only hemorrhagic tissue. So basically the biopsy didn't really tell them much about the tumor cells themselves. And
Which is one caveat that, in essence, if you do go in to do a biopsy, you don't leave the operating room until you know you have lesional tissue, which means you do something called a frozen section. So you take a piece, call your pathologist to the room, and you give it to him directly and say, tell me whether there's some type of tumor or not. And on frozen section, they can usually tell you the quality of the tumor and whether it's adequate to give you a diagnosis. And if they can't, then you go get another piece or pieces until they can. So that's one thing that we would definitely have done.
Like how long does that take?
So believe it or not, a frozen section can be done in a matter of about 5 to 7 minutes.
so in the US, while the surgeon still has the child open, they would already know if the biopsy, well, one, if they had enough tissue, and they would know a lot more about the tumor. So the decision on whether or not to, how to proceed would have a lot more information.
You just need to know that's lesional tissue. You don't put the gun to your pathologist's head and say, tell me the type. But you just say, is it normal or is it not normal, or is it adequate or is it not adequate?
Just scar is if you just want to make sure you have abnormal, you see abnormal cells, and you have the sample from the tumor.
So luckily, Gianna started chemotherapy. She's done, I think, about 2 or 3 rounds of it by now. So they're going to try to redo surgery after it's shrunk and the surgeons feel more comfortable. She will have to have radiation, as I mentioned, across the entire abdomen. All right. So Carlos, can you tell us a little bit about what happened between surgeon and pathologist 8 days later when this biopsy came back? She's telling him nothing.
So I think what happened is, as Chris said, what we want to know before we close is whether it's tumor or not. So this patient did not have diagnostic tissue. The pathologist probably said, well, you gave me necrotic tissue. This is not diagnostic. And the surgeon would probably say, well, tell the pathologist that I removed tumor. And then the oncologist would go to the pathologist and say, he says that he and then I said, well, tell him that actually there was no tumor. Well, I think that took 12 days. Until then, as part of our training, we were talking with the doctors and said, well, it's been 12 days, there is no tissue, forget about this, there is no diagnostic tissue here. And that's, we need to make a decision. Maybe we decided to start chemotherapy because, yes, we can start chemotherapy without diagnosis, which is what Chris was mentioning and Paola. And again, you will discuss that later, right? So in those tumors, you can start without diagnostic tissue, and then you will remove them.
But that is not the norm.
Not the norm
Probably
for
with
us.
this, yeah.
But we thought that going back to the operating room, opening up again, it doesn't make any sense.
In this case, did they not have this tissue because they didn't have frozen section?
Because probably the tumor was so huge, and that happens, Chris, right? Tumors have necrotic areas, particularly if you biopsy the periphery of the tumor, or in the part of the tumor, you could have not viable.
So really quickly, kind of the things that Alex mentioned about what went wrong was clearly there's miscommunications between the oncologist, what they need to know out of the surgery, what they want out of the surgery, the surgeon, whether or not he was really prepared to do the surgery, if he had all the information he needed. Between the surgeon and the pathologist, there was obviously a lot of problems. One of the questions is the training of the team. Did the surgeon know beforehand that a biopsy would increase the risk? Did he know that he needed to get to make sure that he had good tissue samples? And then, as they've all mentioned before, that this is really a team approach to care, and here the team is not functioning properly. So I guess, yeah, we'll start with one possibility, which is improving protocols.
So,
Well, remember the multidisciplinary care. I think that here we all meet, once a week, twice a week, and we review the cases together with the pathologist, with the surgeon, with all the members of the team. We go to pathology and we see that these multi-animal microscopes with the surgeon, with the radiation oncologist. The communication happens because we have multiple opportunities to discuss. And that's key to us, and it's not easy here, so it's let alone in places where, the members of the team are always back.
So one thing we mentioned is that you can't do chemotherapy without surgery. So there's kind of two big people in the world of pediatric oncology. One is COG, which is the Children's Oncology Group, which is the U.S. Protocol people, and the other is PSYOP, which is a French name that I'm not going to pronounce, but it's basically the Europeans.
The International Oncology Society.
Double up. And basically, the standard protocol, if you have a renal tumor in, or what you think is a renal tumor in Europe, is actually to give 4 to 6 weeks of chemotherapy, and then attempt to do surgery. And then you do all the staging off of this surgery, kind of assuming that there might have been some changes due to the chemotherapy. So we want to put this out to you guys. What are the pros and cons of doing surgery first or chemo first in a setting like the US and Europe where you have high resources versus a low resource setting?
I just imagine if you had chemo first, the tumor might be smaller by the time you operate.
Has anyone heard of abandonment of treatment? So this is not a big problem in the US, but in many developing countries, depending on the type of tumor and treatment involved, sometimes up to 20 to 30% of children will actually just not come one day. So they're supposed to have chemo, they're supposed to have surgery, and they don't show up. And most of those children will eventually die because when they do come back, they have widely metastatic disease, and in these situations we don't have the resources to go out to after every child.
Sort of on that note, what sort of resources are available for the children here in the hospital? Like if they're living really far away, are there any resources for them and their parents to stay in the area?
So that's very variable. In the Dominican Republic, in Santiago, they have a home where they can stay. So the local NGO has equivalent to like the Ronald McDonald House here. So they have a place where they can stay for short or extended periods of time during therapy. That's not the case everywhere. But it's so your comment is the typical suggestion we get, not only in Wills tumor, but also in sarcomas and in other tumors. Of course, the volume of tumors in developing countries is sometimes massive, and attempting upfront surgery when you're intensive care, anesthesia, and all the other things you need to do a big surgery, when they're not as good as you would want to, we always get the question, can we give some chemotherapy to shrink it? Where we run into a lot of trouble is when we say, sure, so give 2 cycles or 3 cycles, and then it shrinks, but it's still not small enough for them to want to take it out, and then, but can you give more chemotherapy, or can you change the chemotherapy? And then a surgery that should have happened either up front or in the first few months ends up happening 7 months into therapy, where you may already have sort of selected for a clone, you may have already selected for sort of eventual metastasis and things like that. So we always struggle a little bit with, yes, we can take that approach sometimes of wanting to shrink the tumor to some extent to improve the surgical outcome, but sometimes then we get pushed much further than we feel comfortable in terms of waiting. Because we know, again, surgery is not enough, but chemotherapy is not enough. So sooner or later, if you just do chemotherapy, you are going to select for a resistant clone.
And there are that very small number of cases where CRIS can be the sole cure.
Yes.
And so.
And you have to understand that in some countries, they're so resource poor that the family will be told, you have to buy everything. IV tubing, the medications, and that you have multiple children at home, and you're caring for multiple generations of family under one roof, discussions well beyond what we can do, but talking to colleagues in other areas where that is a problem, those are recommendations that are routinely given to families. Not necessarily for a tumor that has a 95% cure rate, but tumors that are certainly far less.
And then we just wanted to bring up, so the international branch of PSYOP is called PODC, which I also don't remember what it stands for.
Program for Developing Countries.
Yeah. And they basically are coming up with protocols for every resource setting. So they have setting 1, which is low income countries, setting 2, which is low middle income country, and setting 3, which is upper middle income. So the DR would be considered setting 3. It's all based on that World Bank classification. And they actually just came out with the Wilms tumor protocol for setting 1, and they're recommending the PSYOP approach of giving 4 to 6 weeks of chemo and then surgery.
So what's the risk of the tumor isn't a Wilms tumor? Do you have an idea? What percentage of children present with an isolated renal mass that isn't a Wilms tumor? About 12%. So there is a discordance rate, about 12% of looking at it, saying it's in the right age, right this, right that, it's a Wilms given. So you can be wrong if they're not a lot. So if you play the odds, you'll be okay.
And I don't think of any other forms with.
No, but I was just going to ask, so if you are wrong, would chemotherapy or surgery be more effective?
Well, the other thing you have to remember is not all tumors get the same type of chemotherapy, just like not all infections get the same antibiotic. And some of the other, shall we say, renal-based malignancies get very different chemotherapies.
So the COG approach in that scenario.
So it's an ongoing discussion. The COG approach is really the North American approach versus the European approach. They were far more concerned about upfront perioperative morbidity and surgical risk factors. We were not, for various reasons. Who's right and who's wrong remains to be seen, because there's a lot of data on either side of the Atlantic Ocean espousing that their method is correct. Suffice it to say, in either hands, it's a very good outcome, almost regardless. What you're really talking about is parsing out the risk of the treatment. Is the risk of the secondary effects of some increased treatment from the PSYOP approach equate to the perioperative risk in the North American approach? It's hard to compare apples to oranges. I will say that but the chemotherapeutic agents used in Wilms tumors are the same ones used that were first described for all chemotherapy. So Goodman and Gilman from the pharmacology textbook thing were the first one to develop and define the use of chemotherapy to treat cancer. That was in 1927. It was rejected by every medical journal except for the American Journal of Surgery. They developed drugs in the lab, gave them to rats. The rats developed tumors. They gave other drugs, and lo and behold, those tumors shrank, and hence came the nitrogen mustard compounds. Sidney Farber came up with one chemotherapeutic agent, dactinomycin, and unbeknownst to him, in Houston, the predecessor to M.D. Anderson, came up with vincristine. They used single agents for Wilms tumors, and really since the 50s, those have served the backbone to this day for the treatment of that on either side of the pond. So the therapy is old, effective, and cheap.
I just wanted to ask your experience in children. Do you run into the problem when the kids get so sick from chemotherapy and surgery is delayed, or vice versa? For example, you do surgery first and then they miss the chance of chemo?
Well, since we're in North America, your former question really doesn't apply too much, because again, the vast majority of the time we're taking it out. So in this state cancer, no. In others, yes.
The other thing to consider, which was definitely in discussion within the POPC group, is yes, you can do the European approach of giving chemotherapy first, but then you run into the problem of needing a well-trained pathology to be able to interpret a sample, a post-chemotherapy sample, which is not necessarily as easy to look at as a sample that has not received chemotherapy. And so you have to sort of, balance depending on what you have. Because one of the key features, as Carlos was explaining before, is this concept of anaplasia. So if you see very typical cells, that really increases the risk of this being a tumor more chemotherapy rather than less. And so if you take the European approach, but your pathology is really not comfortable looking, not well trained at looking at these samples, then you actually can make a lot of mistakes of just missing some of the key features. So it's sort of, do you want to shrink the tumors to make the surgery better, or do you want to make sure the pathology is sort of a good sample that you can look at up front? And I think it depends a little bit on the setting. The SIO protocol has been used in other locations and has been fine, but we know from experience that pathology is usually a big issue in terms of interpretation.
So we've gone through a few things that have been lacking. So there was communication, there was a little bit of timing issue. Potentially, was the surgeon prepared? What was his multidisciplinary team like? And then, was the protocol the best? And so we should have a few questions for you guys. What do you think you need for proper surgical oncology?
That was maybe lacking in this.
Is maybe lacking in this case. Yeah. What concrete things could be improved? Communication, maybe? What did you say? Better imaging.
How do you go about doing something like better communication?
I don't know, meet more frequently, get together, like you guys do, just talk it over, make sure there's no mistakes.
And having dedicated staff that works with surgical oncology specifically.
Perfect. And how do you get that dedicated staff that works specifically?
Have training resources.
And then there's this big question of, yes, we can train surgeons, we can get a dedicated staff. They're not going to be ready for a couple of years. How do we actually deal with the kids who are in the hospital right now who need surgery?
But think about what other things do you need other than better imaging, some communication, training?
Just the tools like the frozen section and the pathology lab, pathologist that's ready to look at those kinds of samples, anesthesiologists that are prepared to take care of complicated patients like this who have livers up in their lungs.
Who's been to IKEA to buy a piece of furniture? All right, so just about a lot of people. So if you haven't done to IKEA, you make some place. And you put together a piece of furniture. So for those of us who aren't attending Klein, I have to read directions. Before you even get to the directions on how to put hexagonal nut A on screw C, what's it tell you need? What should be in the box, right? If you go through, it should be the parts in the box, because if you don't have all the parts in the box, you can't put the chair together. Or if you do, it's probably not going to work too well. So if you just think about it, what are all the parts you need to care for the child? And those have to be available. And it goes beyond just the practitioners, because we're not at the bedside. It's the nurses, it's the social workers, it's the family support groups, it's the physical structure, it's the equipment, it's the machines, it's the ICU, it's the anesthesia machine. It's a blood bank to make sure that you can get blood transfusions of whole blood or otherwise. In addition to all the medical care that goes into pharmacies, respiratory therapy, physical therapy, are there crutches, bandages, equipment, and all those things. So if you really think about it, take a step back, to take a very simple analogy, what do you need in the box to put the whole thing together? And you really want to have those available. And that's what it takes.
Excuse me, another question then. We need to think about how much time it will take to get the entire line into it, right? You're going to start at
Correct.
10 at night, that's probably by 11 you will be tired. So that's impossible, right? So,
And you build it one piece at a time. And if you don't have it locally or expertise directly locally, then you try and see if you have it within the community or region that can access it.
And last year we had a similar situation. For example, we had a kid with an osteosarcoma and metastasis, and then we kept hearing, oh, the surgery is delayed, and the surgeons want to go, and so we were sort of, and it took us, and it's sad that it took us so long to realize that the item that was missing is they needed a chronographer for the, so they could monitor the CO2 levels during the, or at another time they needed a special BT tuber. So sometimes some reason, sometimes it took us far longer than I would have expected to identify sort of these things we take for granted. We have all the equipment that we need, so if we have the people and the timing and with the OR time, it gets done. But here you actually have to look at everything that you need, all the pieces for monitoring, before, after. Do you have the ICU bed when the hospital is full of kids with dengue fever and the ICU is completely full? Where is the kid going to go after surgery? When pediatric oncology is not the priority. And so there actually are so many, once we started looking at all the places where things go wrong, it was not as surprising as before why most kids get their surgeries late.
So in the last like 5 minutes or so, we did a little bit of discussion of how the plan is going forward to fix the problems that you guys have seen while you're there.
Here's one thing that I would do to Paola is in oncology, you talk about tweeting, you talk about, teleconferencing and web conferencing. That's what Paola and I do. So we meet once a week, twice a week, doing the cases, we see the x-rays on the computer, we tell them what to do. Well, we need to read the pathology, send me the blogs, we'll review that with our pathologist, then this is how you should react. You see the patient again the following week. So we have time, right? There are always urgencies, but we have time to train, to educate, but you cannot do that with surgery, right? So you have that model of that tweening, that partnership, that distance learning does not work for surgery because it's a hands-on process, right? I don't think that Chris can see once a week, how did the surgery go, right? And then, well, the kid may be dead, right? Or maybe there was a mistake on the other. So we had to come up with a different model for this, right?
So it's still very much a work in progress, but basically after, so some of the things we've identified are a big problem is the communication, which we talked about, but also more than communication, we've really faced an issue with there's really no pediatric oncology surgery, sort of it's a rare field as it is, and so most of the surgeons locally are actually adult oncology surgeons that don't necessarily want to deal with kids, don't feel like they have the experience, don't feel like they can do it, and then the general pediatric surgeons don't feel like they have the oncology expertise to do the surgeries, and so we've encountered a lot of difficulties with the surgeons committing to do the surgery, someone willing to go through surgery, and we acknowledge the reason. Neither one or the other has probably the right training or the right expertise, so it's not their fault. They just, they're acknowledging that they're not willing to do it. So I think a big part of what we realize is we need to do it at the same time. So we need to identify someone locally that's willing to learn and take the lead, but at the same time we can't bring this person here for a couple of years, because what do we do with all the kids that show up over the next 2 years? We at the same time, different to what we usually are accustomed to, actually need to travel there and do some of these surgeries. Many surgeries actually can be planned in advance. Here we tend to think of oncologic surgery almost like an emergency, like we see that the kid shows up with a little tumor and we want the tumor out in 3 days and we want the diagnosis in 7 days and we want to start chemo by day 7 after surgery, and sort of like we get everything done very quickly. And that's correct, but it doesn't mean that we couldn't assume more sort of the European approach and actually do chemotherapy until we know the right surgery is going to be done. And the same thing for sarcomas and other tumors. So what we're trying to develop is sort of a combined model where we have someone locally that is willing to do the things that the biopsies, the things that can be done ongoing, and then have sort of a training. The other problem is that if we bring someone to train here, with all our medical license and observership policies and this and that, this person would come here and probably not be able to touch a patient. How much can you learn as a surgeon without being able to touch or actually participate in the OR? So we probably have to move the training locally. So that entails bringing a whole team of surgery, anesthesia, nursing, and then actually train the local team in their own setting. And it definitely will be a learning experience for us in terms of what can be done and what you need, and can you actually get these surgeries done in that location, or what is the best location. So we've even talked about, we're still deciding, is it the local hospital that we're working with the best place, or should we be renting an operating room for some time from a different location? Should we be doing it in the capital? So there's a lot of things going on, but bottom line is we think we have to do a combined system where we actually bring a lot of the training and we do it locally. But that means a lot of traveling for Chris and some of our other colleagues.
I mean, at the end of the day, these are very rare issues. You know, the incidence of breast cancer in women, adult breast cancer, non-genetically based, one thing. More women are probably diagnosed with breast cancer on the island of Manhattan in a week than enormous tumors in a year. Probably even more all childhood solid tumors. And so it's a numbers game. And, you know, there is a mechanical component to what we all do. Whether it's administering chemotherapy, doing an operation, intubating the child, and getting them through the operation, delivering the ICU care afterwards, the more you do, the more experience you have, the easier it is to recognize, shall we say, impending problems to try and solve them before they happen. But it takes experience to do that. And therefore, in situations where it's rare, cohorting is a good idea. Because, in essence, experience brings wisdom, and wisdom makes for good outcomes based off of decisions on parameters that you see in front of you. And in situations of just not this, which is rare, but a lot of rare diseases, that's why there's centers of excellence and people who focus in on it. Because if you see it every day, or if you do it every day with the same team, you get better at it. Maybe individually, but really it's a collective. And so that collective expertise has to be centered in a situation whereby not one is done in this hospital and one is done in that hospital and 3 are done in this hospital every year, every other year. Or take all 6 and do them in the same hospital, the same group, year in and year out. And though that may not seem like a big number, if you do 6 of one tumor and 6 of another tumor and 5 of another tumor, all are in the abdomen, there's a lot of overlap. There may not be specific overlap with the type of drugs we use and the type of surgery that will be physically performed, but the anesthesia, the ICU, the blood bank, pharmacy, the pre-op, the evaluations, the CT scans, the protocols, everyone kind of get used to it. And so there really is a benefit to repetition to really try and gain expertise.
So then the idea is to go with the team every X number of weeks. That's Chris Welder, Paola, then the anesthesiologists, the intensivists that will help with the postoperative care, the nurses pre and post, with you know, a local team that is assembled around that same team. So over 1 year, then you start probably doing the easiest surgeries, and then you escalate the most complicated surgeries, while the easiest surgeries then are done by them. So that's basically try to build it up over 2 years, and then have some outcomes that you want to measure, right? You don't want to start a project without knowing how you're going to measure success. Right?